I am Megan McCarthy. I'm the vice chair for the San Francisco VA, and I am delighted to introduce our esteemed colleague, Dr. Shira Maguen. This is really a delight. Dr. Maguen has been a clinician, educator, and researcher here at the San Francisco VA and a professor in residence in the Department of Psychiatry and Behavioral Sciences for more than 20 years. She is an extremely prolific and brilliant researcher in the areas of PTSD, women's health, traumatic brain injury, eating disorders, cognitive behavioral therapies, suicide prevention, and moral injury and killing in war. In addition to this extensive research program, Dr. Maguen provides clinical services to veterans with PTSD here at the San Francisco VA and is a highly sought after clinical supervisor for our psychology externs, interns, and postdocs. She has won way too many awards to mention here. Most recently, I'll mention that she was awarded the Robert S. Laufer Memorial Award for Outstanding Scientific Achievement from the International Society of Traumatic Stress Studies. In addition to all of this, Shira is a beloved and incredibly generous and insightful colleague. Over and over again, she's always willing to help with perspectives that always further our conversations. And as another colleague once said to me, Shira makes everything better. And I think you all are going to see that today. So with that, I'll turn it over to Dr. Maguen.
Thank you for that beautiful and warm welcome. It's so great to be here today. Very excited to share more about moral injury with all of you. I hope that by the time that you leave today, you will be able to know the definition of moral injury, talk about how it's different from PTSD. I'm going to focus on measurement and treatment as well, and talk about the suicide risk that is inherent with moral injury as well. And then I'm going to also cover actually some recent work that we've done that I haven't talked about before. So there are several new studies that we just had that came out that I'm going to be presenting for the first time here today. So I'm excited to share that with all of you for a first look. And I very intentionally chose these photos representing, the first is a soldier, and that really represents the bulk of my work with veterans of war. However, my work in moral injury has really expanded over the last few years, and certainly with the pandemic, also to cover healthcare workers and first responders as well. So I'll be covering work in all those areas. As this work has grown, it's become more and more important to cover not only veterans, where the work really started in moral injury, but to really understand how this shows up across occupational high-risk groups. So hopefully you'll walk out with a better understanding of the prevalence in all three of those groups. Okay, so it's always tough to define moral injury, but I'm going to offer several slides where I define and then break down the definition of moral injury. So here you can see that the top way that we define moral injury is the distressing psychological, behavioral, social, and sometimes spiritual aftermath of perpetrating, failing to prevent, or witnessing events that go against an individual's morals and values. And really, I think with moral injury, it requires an act of transgression. So the individual has to feel like they have crossed a line somehow. And that's really critical. And we also know that betrayal can be a big part of moral injury as well. So I'm going to really break it down a little bit further and just share that moral injury requires both an exposure to what we call a potentially morally injurious event, and you'll see that PMIE throughout the slide. So that's the exposure piece, and then symptoms that follow. And so if we're going to focus on what the exposure is, that looks in several different ways. That can be witnessing something that transgresses your morals and values. It can also be perpetration. So that can be directly active commission. You did something, right? So you killed in war if you're a veteran. And that can also be acts of omission. So if you're a healthcare worker or first responder, you fail to save someone, and as a result are really struggling with that. This is a really important slide to me. So I think that as media attention has grown and more people are becoming aware of moral injury, people use that term a lot. And I want to really have us think about moral injury on a continuum. And so if we think about our day-to-day lives, we are presented with moral dilemmas on a daily basis. And certainly during these turbulent times, that happens frequently. And so I want us to think about this on a continuum with, on the left-hand side, if you're presented with a moral dilemma, a very normative reaction is to have moral stress, right? And so this is a low-level stress that is very present, and yet it can also motivate us to do things like advocate and also, go out there and try to get things changed in the world, right? So advocacy. So moral stress is at the left-hand side, and typically people who feel moral stress don't have long-lasting impairment because of that stress. Then the next piece is moral distress. And so that's a little bit of a higher level of stress specifically. And I think this is a shorter term stress reaction due to some exposure crossing your morals and values. And people have some short-term impact on functioning, some frustration, some helplessness, but it's not in that red zone, right? So then if we go to the red zone, that's moral injury. So moral injury is really a long-term reaction to those stressors, that moral dilemma, the moral stressors. And that is, you have profound and long-lasting impairment and symptoms, right? And so we're going to talk about what those symptoms are in a moment. But when we talk about moral injury, we really talk about those individuals who are struggling, who may need help and may need extra support. We're not talking about, moral stress or moral dilemmas. So I think it's really important that we take the language very seriously and think about what we mean when we use moral injury. So how is it different than PTSD? I think this is a question that comes up a lot, and I'm going to offer, my thoughts about this. And of course, we can kind of think about this together as well. But in traditional PTSD, the models that are used to treat PTSD really focus on life threat, victimization, and fear and horror as a reaction. So it's really about what was done to you. And a lot of our treatments are, again, based on exposure of some of those reactions to trauma. Moral injury is really your transgression of consciousness. It's an internal struggle because of something that you did. So there's agency in moral injury, and there's acts of commission potentially, and shame and guilt are really the hallmark symptoms that we think about when we think about moral injury. And so it's really about, what did I do or what did I witness, right? So keep that in mind. There's very different questions with moral injury. And so what's the clinical gap? So for me, where I sit, the clinical gap is that I'm using evidence-based treatments for PTSD in the clinic. So prolonged exposure, cognitive processing therapy, and those will only go so far because they're based on different models, right? And so the idea is we need more than just that typical cognitive framework to treat moral injury. So this is a busy slide, but I'm going to really direct you to the cognitive core, because I think for me, that's really where the differences pop. And so with PTSD, the cognitive core, the thoughts that people have is, I'm not safe, the world is dangerous, right? And so those are typical fear-based responses to trauma. With moral injury, it's about the person oftentimes. I am bad, I'm evil, I deserve to suffer, I failed to do something, and as a result, I deserve to suffer, right? And so I'm a monster. You'll hear, I'm going to share some quotes and actually some videos too later on of individuals, and you'll see kind of, people speak for themselves about what they did and how they feel about that. And that's really the core of what we're dealing with in moral injury. So here is kind of just a breakdown. And when I talk about measurement, I'm going to go into lots more detail about the symptoms. But if we think about, what are the key symptoms, this is really a schematic of that. So shame and guilt are at the forefront. It's about feeling badly about what you did and who you are. The social withdrawal is different in moral injury. So it's really about, I did something horrible, and if people knew, they wouldn't want to be around me. So I'm just going to keep to myself so people don't really get to know who I am. And with that too comes a lot of self-sabotaging behavior. So because I did these things, I don't deserve to be happy. I don't deserve to have a family, to be successful at my job. So these are all symptoms that tend to travel together. So I'm going to share now some slides. This is some videos. This is About Face is a project that I worked on with the National Center of PTSD. For those of you who are not familiar with the website, I encourage you to check it out. So it's a lot of stories of veterans telling about their experiences and their treatment in great detail so that people can see others reflected and really understand that they're not alone and get to hear about other veterans' experiences. So I'm going to share 3 very brief vignettes with you of veterans speaking about their moral injury. And I think the first 2, all 3 are veterans. The first 2 are going to talk about their war experiences. The last veteran is also an MD who served during war as well. And so you'll get to hear about her experience as well. And I apologize, after each vignette, you'll see some ads, which I cannot control, but they're going to be there. So very briefly.
Because of the misfortunes of others based on me. And so that gave me guilt. And when I felt guilty, I feel like I wasn't deserving of anything good to take place in my life.
Okay. So again, you hear sort of the feeling about guilt and feeling like the person isn't deserving. And I'm going to move on to the next. I'm glad that the sound is working okay.
I'm going through different missions and I had to hurt someone. But once I got back to our fob and I got back to my room and I'm laying there in my bed, inside of my head psychologically, that is playing through my head. And I'm just saying to myself, I just killed someone. I just hurt someone. And in a normal situation or scenario, I probably would be in jail. Am I going to go to hell for this? Am I going to feel a way where I'm going to be punished for what I just did? And when there's no answer to things like that, it really, really hurts mentally. It hurts you physically. It hurts you emotionally, to the point where you don't even understand where the answers are going to come from when you're going through some of these feelings that you're replaying over and over and over inside of your head.
And then finally,
it's hard for me to say how it affected me with the immediacy of being in Afghanistan. I knew that I didn't feel well in Afghanistan. I knew that I was struggling, especially the last 3 months of my tour, because I just had that knowledge background that something wasn't right. But once I returned to the United States and was seeking more intensive help for where I was at, coming back from being deployed, I was able to identify that disconnect between having been over there, seeing and witnessing people that were injured, knowing that I couldn't assist them, was a disconnect between my internal core values and the expectations placed on me within service.
Okay, so I think we can see here that,
Didn't think I did.
Okay. We can see here with those vignettes that, again, it's about both what you did, right? And, the unanswered questions, the ruminations about what you did, and also what you couldn't do to save people, right? So really getting to hear from the veterans themselves. So how do we represent all this, right? In our clinical work, in our research. So up until about a few months ago, there really wasn't a way to code for moral injury. And just as of September, it's super interesting, moral problem was added as a Z code. So what that means specifically, so it's not a diagnosis, but moral problems are now other conditions that may be a focus of clinical attention. And so what this does is it sort of says there's not enough research perhaps to put it as a diagnosis, but we're going to put it in the DSM as a way to just capture that there may be something that needs clinical attention that's important to attend to. So I wanted to put the language here. This is kind of like a very new development, but I wanted you to see here that it was grouped with the religious or spiritual problems. And I've put the edits to this in blue. So you can see moral was added, and then moral is defined. Moral problems include experiences that disrupt one's understanding of right and wrong, a sense of goodness of oneself, others, or institutions. So again, very, very broad, hopefully that captures it all. But I think, there over time, hopefully there'll be more specificity as well. And I want each of you to kind of think through, given what you've heard so far, should moral injury be a diagnosis or should it stay as a Z code? So this is a very hotly debated topic. And I want each of you to kind of think about the pros and cons in your mind of having it more as a diagnosis versus a Z code. So I think a lot of people argue that putting it as a diagnosis really increases the stigma around moral injury. And yet, also if people are coming in for services for moral injury, it allows for a way to more officially code for that as a diagnosis. So, so I think that there's people arguing both sides of this, and think about for you where you land as we go through this talk. Okay, so the point that I want to make here, this is a model that we worked on. So all the work that I do is, with groups of people who really, we approach this from many different perspectives and allow us to kind of think this through in many different ways. And I'm going to acknowledge them all at the end. But I think that here, what I really want to focus on is that we've been focusing a lot on the individual, the event specific definition of moral injury. And so that's really like, you have this exposure, you have these thoughts in relation to the exposure. I'm a monster, I don't deserve things. You have shame or guilt, you have withdrawal, and then you have difficulty with self-forgiveness. That's another key symptom of moral injury. And then you may have, self-sabotaging behaviors or other behavioral ramifications of that. So that's all at the event-specific level. But we can't really think about moral injury without extending the lens, right? And so there's going to be multiple factors at each of these levels, right? And so at the individual level, there's, what your moral identity is, what your personal values are. At the interpersonal level, how you interact with people and get support around that. If you work within teams, it's your cohesion within those teams, whether that's as a veteran, as a healthcare worker, first responder. Then, of course, if you broaden the lens out even further, there's the organizational level. If there's institutional betrayal, that's going to factor into things. It's the leadership and support that you get at every level, and the climate in your environment, right? And then the last lens is kind of through the societal lens. And so it's what is the public policy? What is the law around some of these things? How do we incorporate and see this through the lens of inequities as well? So the next thing I'm going to focus on is the prevalence of moral injury. So this is a big question that comes up as well. And so I want to, again, have you remember that we're going to talk differently about exposure versus actually probable moral injury. So those are, I'm going to show you the numbers for each. So we did a study, my colleagues from the National Center for PTSD and University of Arkansas did a study of over 1,200 nationally representative healthcare workers, first responders, and veterans. And what we found was that about 1 in 2 participants endorsed being involved in an event as part of their work duties that they perceive to be morally wrong. Okay, so that's 50% endorse that exposure. However, only 1 in 20 participants screened positive for probable moral injury. Okay, so again, just like with PTSD, a lot more people are exposed to trauma than actually develop PTSD. Just so that's the case with moral injury as well. So that's a study that we did. I want to also just share that we did a scoping review of 185 studies among healthcare workers. They found very similar rates, right? So 50% of healthcare workers reported exposure. And in that scoping review, about 40% reported that they had some moral injury symptoms. I'm now going to switch to some of our work with healthcare workers. I've been really lucky to work with colleagues at San Jose State and with the San Francisco Fire Department too. And now that's growing. We're doing a national study of first responders as well. But this is just some of our preliminary work that we haven't presented before. So this is really two different articles that have come out. One is really going to focus on the exposures, and the second is a qualitative study. These are both out, and I'm happy to share them if people are interested. So what we found is that in first responders, exposure was absolutely the norm. And so you can see here that first responders, including EMTs and firefighters, said that they witnessed things that went against their morals and values, pretty much 81% of the time, and that about 50% reported acts of omission, failing to do something, or acts of commission, doing something that actually went against their morals or values. So I'm briefly going to talk about the themes that we found, and first responders talked about many of these things continuing to haunt them. So this is something, again, that stays with them. And we really found 7 different themes of the types of potentially morally injurious events. So they reported that they witnessed suffering. They had concerns about not saving or harming patients. They witnessed harmful behavior to patients. They witnessed poor behavior towards colleagues, and that, sometimes they didn't speak up. They acted unprofessionally themselves. They had to deal with system failures and value tensions as well. So I'm going to just, in the interest of time, I'm just going to share a couple, just like we made the veterans' voices come alive. I want to share a little bit about what they told us. And so one theme that emerged was really the weight of responsibility. So the guilt of almost saving someone, for many of them, they felt like they didn't have enough resources to save people. For others, they felt like they just didn't have the time or their support, or, just made some mistakes along the way. So here's a quotation: lots of little things that I could have been done a hair faster. I constantly wonder if any one of those things would have made the difference around a patient that was lost. And then, they also talked about betrayal from within, the distress of seeing colleagues mistreat either vulnerable patients or also bullying within the ranks, right? So that's a topic that came up. So I witnessed behavior towards other members that both violated my moral values and weigh on me. I wish I wasn't afraid to use my voice. And I think this really highlights again that there's a rank, right? And sometimes people feel like they aren't able to speak up and live with that guilt afterwards. I'm going to move on to another serious topic, which is very important to me, which is suicide and suicide prevention. This is something that we've done a lot of work on in the VA and think about a lot with our veterans. And in this article, we really wanted to look at this in not only veterans, but in all 3 groups that we've been talking about. So we also wanted to understand the relationship between suicide risk and moral injury specifically. So this article just came out very recently. So what we found, unfortunately, is that those with clinically meaningful moral injury were over 3 times more likely to report suicidal ideation in the last 2 weeks, and 6 times more likely to have a lifetime suicide attempt. So this was after adjusting for demographics, after adjusting for PTSD and depression as well. And you can see here the odds of depression, of PTSD, and again, 6 times increased odds with probable moral injury. So that's, I think, to me, that's really a wake-up call, right? Like, we need to be doing something differently in order to understand folks who are at risk and may not be captured otherwise, who are having some of these thoughts or unfortunately some of these behaviors as well. So that brings me to how we measure moral injury. And I think that this is something that's really developed over the years. So when we first started doing this work, there were measures out there, but there were lots of different issues with the measurements, which I'm going to kind of talk about. But I think one of our motivations with developing a new scale was really to think about how does this not only appear in veterans, but across groups. How does moral injury show up? So I'm going to just very briefly talk about the MIDS is the tool that we developed that I'm going to be telling you about. It's stands for the Moral Injury and Distress Scale, specifically. And so I'm going to talk about what the limitations were in previous measures and why we developed the MIDS. So as I mentioned, prior studies had only focused on measurement in veterans. We really wanted to extend that to also healthcare workers and first responders as well. The other piece is that the measures that existed conflated exposure with the resulting symptoms. So oftentimes you'd see those mixed together. So there wasn't a clear separation. The MIDS really delineates the potentially morally injurious events and the symptoms and has those separate. So you can see both those pieces. The structure was also quite inconsistent with prior measures. There were inconsistent factor structures, sometimes more than one, and then those factor structures were just added together. And so there was, some issues with that. And so we developed a scale that had a single unidimensional measure, so it can be easily summed, easily used in clinical practice. And then the most important, perhaps, thing is that, that you have to index the symptoms to the actual exposure. And so if you just ask generally, do you feel guilty? That can be really about anything, right? So you have to say, do you feel guilty about this event that happened to you? And so I think that that's really important. With the MIDS, we really made it clear that these symptoms are indexed to the event that you just told us about. So I'll just say we did a multi-phase kind of process to develop the MIDS, item generation and content validity. We had that reviewed by experts. We did a lot of pre-testing and interviews with stakeholders and healthcare workers, et cetera. We administered a large survey, and then we did the validation and found that it had very good reliability and validity across all three samples. So I'm going to talk a little bit about how we think about the MIDS and using the MIDS. So, and I'm going to share the specifics with you. So the first part is about exposure, right? So did you participate in a morally injurious event? And we ask about how distressing that was. And then we ask about 18 symptoms specifically, which I'm going to share with you as well. And then we also did a lot of work to determine a cutoff score. So this was the first moral injury measure where there's actually a cutoff score. So this allows us to say, this is probable moral injury, right? Versus you're having moral injury symptoms that are distressing, but it's not clinically significant moral injury. So these are the 18 indicators here. So I'll let you guys read through that and take a look, but you can see they span, a lot of emotions, a lot of behaviors, spirituality, betrayal, et cetera. So I'll give you a moment to look through that. And I'm going to show you what that looks like. I'm going to show you some profile analyses and factor structures too in just a minute. So you'll see what that looks like kind of in practice. So, but first I want to focus on what is a score? What does that cutoff score mean? And how does it travel with other diagnoses, other issues? So if you score 27 or higher on the MIDS, which is probable moral injury, 76% of people also screen positive for PTSD. So very high rates of kind of comorbidity, so to speak. Then 68% screen positive for depression. 54% report severe guilt, again, not surprising. And then 46% report, clinically significant functional impairment. So what are the demographic vulnerabilities? Again, if we think back to sort of the dimensional model of moral injury, it's not surprising to know that minoritized groups had 2.5 times higher odds of screening positive for moral injury. And so that's been pretty consistent in our studies. We need to definitely do more work about that, and qualitative studies would be really important to kind of tease that out. However, there's a number of factors that also don't differ. So, among, for example, veterans and healthcare workers, no differences among those groups and no differences among men and women. So this is literally published a few days ago. And so I want to just share with you, we did a profile analysis of moral injury. So what you can see at the bottom is the 18 symptoms, and then you can see on the left the symptom severity. And so if we look at what are the profiles of moral injury, it really clusters into three groups, right? So, about 75% of folks in these three high-risk groups have minimal moral injury. Again, there's the exposure that they have, which is quite high, but the actual probable moral injury is quite low. Then we have about 20% that are in the moderate range, and then about 5% that are in the severe moral injury range, right? And so you can see, not surprisingly, that those peaks are with guilt, and the other peak is with bad things are going to happen, to me. So I think that these are, again, very, very much part of like the core symptoms of moral injury that we see popping here. And I think this is important for us to know from a treatment perspective. So the cutoff, all of the people who are in the severe group are 27 or above, and some of the moderate group is in that cutoff range as well. So why can't we just measure PTSD and have that be okay? So it turns out that 9.1% of those in the severe moral injury actually screen in the normal range for PTSD and depression. So that's important too. So if we don't kind of measure moral injury, we allow certain veterans who may be at very high risk to fall through the cracks. So I think that's, one of the arguments, obviously, for measuring moral injury. I think there's a lot of other arguments as well. So I'm going to transition to talking about treatment specifically. And I'm going to talk about a treatment that we developed that is specifically focused on killing and moral injury with veterans. I'm going to then talk a little bit more about other types of treatments, but I'm just going to share with you, this is something that we've worked really hard to do. So with my colleague, Christine Berkman, who many of you may know, and many other people, were part of this work as well. And so this is really about how do we create a treatment that goes beyond trauma-focused treatments and really deals with some of the core features of moral injury, including self-forgiveness, including, not challenging cognitions, but really working towards acceptance with some of the things that people did. And so I think that I'm going to take you through kind of the three phases. I'm really going to simplify this quite a bit, but I'm going to take you through the three phases of IOK, and I'm going to share some very hot off the presses. We just finished our multi-center. We had a trial at 3 VAs, and we just finished analyzing that data. Deb Barnes, who's here, helped a great deal with that. We wouldn't have been able to do that without her. And so it really, I'm excited to share some of those very preliminary results with you for the first time here today too. So I should mention too, before we did that multi-site trial, we also did a pilot trial as well, but I won't be presenting those data here today. So what is impact of killing? So phase 1 really focuses on education and identification. So we do a lot of education with veterans who come in about the physiology of killing. So, what happens is a lot of veterans feel that rush in their body when they kill, and they don't understand it, and they don't really understand like why they got kind of, sometimes a rush and what that means about them. And so we do a lot of education about what happens in the body when individuals kill. And then we also look at it from a cognitive perspective. So even though we're looking at cognitions, we really draw from many different theories, including like Gestalt and interpersonal as well. So, but we do look specifically at killing cognitions through a scale that we developed called the Killing Cognition Scale. So more specifically, common cognitions are, I'm a monster, I deserve to suffer. So we want to really understand like where the cognitive piece and where that stuckness is. So some of those thoughts that people have, we're going to target to sort of challenge and work with, and other ones we're going to target for acceptance. So the active work of self-forgiveness is the second phase, and we do a lot to kind of get up to the point of the letters that I'm going to describe today. And so basically what we do is, this is really looking at self-forgiveness from the individual's culture and perspective. So we ask individuals what it means to them, where they get their ideas about self-forgiveness. And there's a lot of writing exercises and a lot of discussion and a lot of work about, what does self-forgiveness mean to you? What is it? What are the barriers to self-forgiveness, right? And so we do a lot of that before we get into the letter writing piece, but this is a very, very powerful part of the treatment specifically. And so we have them write 3 different letters, and each of these letters serve a very particular function. So the letter to the person harmed or killed is really acknowledging the act that was done and asking for forgiveness, right? So that's kind of the goal there. Then we have a letter from a trusted other. So the goal of that letter is really to take a different perspective. And so we want to shake things up and get the veteran out of their worldview and into someone who they really trust to talk about what they did and to talk about the veteran. So we have them, the idea is that hopefully they can shift that perspective and have a little bit more empathy for what happened and for themselves. And then finally, there's the letter to the younger self. And this is really trying to foster more self-compassion, right? And so we try to have them write to a younger version of themselves from their current status right now. What would you say to your younger self who's about to experience this very difficult thing? So as you can imagine, it's really the goal here is to really break that cycle of dehumanization, with that first letter, and then also foster perspective taking and self-compassion with these letters. And then finally, the last phase is making amends and reconnection. So you can't do any of this work without kind of reconnecting to people's values, right? And so this is really focused on acceptance. So what we've learned over and over and over again from veterans is that if you work with someone who feels like they did something wrong and they crossed a line, they're not going to respond well if you try to explain that away, right? And so you have to meet them where they're at. And for many of them, they did very difficult and very upsetting things. And so we meet them where they're at and work towards that acceptance. And without that, this whole treatment falls apart, right? And so that's a critical piece of all of this. You got to name what happened. You got to name the wrong that was done. And you have to sort of sit with that and some of that grief, right? And that's very, very powerful in the therapy room. And so, I think that the other part that we focus on is then reconnecting with the values and reconnecting with estranged others, right? And so there's kind of that functional piece that we have to address that happens in moral injury. So we have them do self-forgiveness plans. We also have them do amends plans as well. So we have them go out into the community and volunteer if that's what is part of their amends plan. Some people choose to mentor others. Some people choose to connect with family that has been estranged. And then there's also a lot of people who choose rituals. So either spiritual rituals or mourning rituals for the people lost. A lot of folks can't go back and apologize in person. So through the rituals, they can get to some of that as well. And that can be incredibly helpful for some people. So again, the goal here is to replace those self-sabotaging behaviors really with these value-driven behaviors that get them in line with their values. And, for many feel like they're making amends through these. So as promised, I'm going to talk to you a little bit about our multi-site trial. So this multi-site trial was at the Durham VA, the Bronx VA, and at San Francisco. We randomized about 100 people, and we compared IOK to a present-centered therapy. It's called PCT. It's been used in many PTSD trials, and it's a pretty active and helpful comparator. So just a few of our results in the interest of time. So you can see here the effect sizes with psychosocial functioning, which was our main outcome, as well as PTSD as measured by the PCL-5 here. So you can see IOK demonstrated that compared to PCT increased functioning. And so as measured by the Sheehan Disability Scale, so that's an effect size of 0.51, and with PTSD, it's an effect size about 0.59. And then with PTSD, importantly, those results were sustained at 6-month follow-up as well. So what are some other treatments for PTSD in veterans? I just want to kind of highlight some of this, and then I'm going to shift a little bit to healthcare workers and first responders. So these, I think that you can see here, these are all treatments that are various stages in development. So there's IOK, which I talked about, that's an individual treatment. There are also a few other individual treatments, including adaptive disclosure, which is about 12 sessions, trauma-informed guilt reduction by Sonia Norman, or Trigger as people kind of call it for short. So all three of those are individual therapies. And then we have some group therapies that are also in development. So the Building Spiritual Strength is by Irene Harris, and that really targets the spiritual components of moral injury, and it can often be led by chaplains as well. And then we have ACT for Moral Injury. That trial is currently in progress by Lauren Borges and Jacob Farnsworth. And again, that's a group treatment. There's also folks in Philly, including Peter Yeomans, who many of you remember probably from his time at the VA here in San Francisco, has gone on to do a moral injury group that's co-led with a psychologist and a chaplain. They also have community events where they invite community to kind of witness veterans speaking about their moral injury to kind of get at those multiple levels of healing. So as we mentioned before, CPT and PE are also sometimes used for PTSD and moral injury. And my argument would be that we need a little bit more for people who do CPT and PE to address some of these issues around guilt and self-forgiveness. So, if we kind of take all this together, how can we put this into clinical practice? Certainly it's something that the MIDS is easy enough to kind of put into clinical practice at places like the VA. We just literally tomorrow, this is happening. It's going to be in the clinical record. And so, it's we're celebrating that because it was a long time in the making, but it's going to be part of, a VHL system, basically, for those of you who are familiar with the systems at the VA. And so you're going to be able, as a clinician, to actually use the MIDS. And we're hopefully going to do, our next study is going to be an implementation study to really understand how to do that most effectively. And so then the idea is that you can use the MIDS, you can use a cut score of 27 to look at those who are having clinically meaningful moral injury. And then you could, if folks are having that clinically significant impairment, you can then put them into treatment. So the idea is that treatment can maybe be a stepped care approach, and so maybe the first step is trauma processing. Usually IOK is used after trauma processing to really get people so that they first are able to talk about their trauma in a supportive environment and know that that's okay. And then treatments like IOK can typically come next. And then, we believe that really this work, you can't do this work in a vacuum. So you have to have that community piece too. And so whether that be connecting the veteran or, whoever is in front of you with their spiritual community, with their other cultural community that may lend support. We work with a lot of Native American veterans who really find that it's extraordinarily helpful after they do this work to also work with their spiritual communities to heal as well, hand in hand. And so I think that there's a lot that can be done with the community integration. We have a long way to go to figure out how to best do that. Okay, so what else can help? So I think that first, expanding the scope. I've talked a lot about how to heal moral injury in veterans. The truth of the matter is that there's very little work in other populations. So there's a lot of opportunity for studies in that domain. We're starting to do some of that with first responders. And I didn't have time to talk about that today, but that's something that we're hoping to work on with first responders by, doing some research in terms of what can be, interventions that can be done with groups of people, meeting them where they're at with their work schedules. So, but I think we really need to expand the scope of treatments with healthcare workers and also first responders. So there are a growing number of studies focusing on healthcare workers. And I think that I want to highlight some work by my dear colleague, Natalie Purcell, who looked at this issue, moral injury in healthcare workers specifically. And what she found was that these were all protective factors that help with moral injury, right? So a collaborative workplace community helps, engaged leadership helps, empowerment to make changes in the workplace, and opportunity to process distressing events for those who want to process them, right? So it's important too that we don't force people to do that, that be optional for people to show up in case they need the space to do that. So those were some findings that she found in her studies of healthcare workers. So again, it's not, I think that a lot of healthcare workers, during the pandemic were like, do yoga or do self-care. And they were like, okay, but I'm working in a system, right, where I need more support than that. It's not only about me, it's about the system too. And so I think Natalie's work really speaks to that, about how important those factors are as well. So, and finally, I think this really highlights the importance of focusing beyond just, again, the individual level, that these treatments that we do necessarily have to be focusing on more than one level of care when we think about that. Okay, so I'm gonna wrap up with just some websites, information, and resources. For those of you who want kind of like a one-pager to give patients about moral injury, I highly recommend, we developed a fact sheet with the National Center for PTSD. If you look up National Center for PTSD and Moral Injury, this will come up and you can print out the fact sheet, you can hand it. Just naming moral injury can be a really good way to start the conversation with people. And I think that can be a way to do that, to just sort of say, hey, does this fit for you? We find that just opening up that conversation can go a really long way in having people just feel heard about what they're experiencing. I mentioned the About Face website, where you could go and get videos and direct people to hear stories of other veterans, not only about moral injury, but actually about PTSD and a number of other factors as well. The National Center also has moral injury in healthcare workers. There's a page on that. And finally, HHS has moral injury for healthcare workers as well, and have a page up on that. So as always, we do this work in community, and there's a lot of people to thank. So, including the veterans, healthcare workers, and first responders who participated in all this work. For our IOK treatment, it takes a village to do that work, for the measurement development. And of course, this is research funded. I'll just end by saying, if you want to get a hold of me and continue the conversation, I can easily be reached at shira.maguen@va.gov or at ucsf.edu. Both of those are very accessible in those two places, and I would love to continue the conversation. So I'll stop there and answer any questions that people have. Thank you. Okay, so we have, I think, about 10 minutes for questions, comments, thoughts, all of the above. Love to hear from you. And I know people are monitoring the chat too, so please let me know if there's questions that come up there.
Morning, Shira. Thank you
morning.
for this excellent talk. What would be your recommendation for who leads the interventions? Considering your thoughtful comments about community building and religious and spiritual life. And I'm wondering if you have a recommendation that maybe it shouldn't be anyone in this room, but maybe peer advocates, family advocates, or counselors, or rabbis, or priests, and considering that you've collaborated with those folks too.
Thank you for that question, Barbara. I think that a lot of the work that we have done with first responders, RAMS has played a big role in that, a lot of peer support specialists, and also within the fire department, there's peer support specialists in behavioral health, that are embedded in behavioral health actually. And so I think that it's really important that a lot of times we feel scary, right? Like mental health professionals feel really scary. And so oftentimes the first step is having these peer-led groups to get people engaged and just have the conversation. What we've also done with San Jose State is have both peers and, researchers or clinicians go in and do those groups together. or have peer led and have, sort of getting to know the clinician, so to speak, and, making sure that that person isn't scary. But we do things also like go in and have dinners with people, right? And so there's kind of a breaking of the ice. Like, I think it feels very scary for clinicians to just come in and try to do some of this work. There has to be a period where you're getting to know the community, they're getting to know you. It's more casual before doing some of these interventions, I think. So yeah, really, really important point. So, and, also if they want to come here, have them come here, right? We're open to that too, but that sometimes that bridge can be a huge bridge. So it has to start by meeting people where they're at on their territory.
Thank you. Very important work and really great presentation. I'm wondering if you've incorporated any of Kristin Neff's self-compassion work.
Thank you for that question. So I didn't have time to talk about that today, but during the pandemic, we actually went and led retreats for healthcare workers. And it was sort of at the height of the pandemic. And it was, Chris Berkman and I would go in and do that. And actually that was a big part of the work that we did. It was a lot of self-compassion, and Kristin Neff is amazing that she makes her material publicly available. And during the pandemic had a lot of that on websites, et cetera. And it's still accessible to people. So I'm a big fan of the work that she does. And if we had more time, I definitely would have talked about that. But I think that she's one of the people who I turn to when I think about self-compassion and how to integrate that, because she's thought a lot about that. And, I think also what we typically do when we go into those environments is do some of the self-compassion exercises, slightly modified or in different ways to kind of capture the population, whoever we're working with. So we were doing a lot of like pulmonary doctors, ER doctors, nurses during the pandemic, and that work was critical. So great question.
You go. Oh, okay. Do you want to go first or? Oh, okay. Hey, thank you, Shira. That was wonderful. I was struck with your slide with the PTSD versus moral injury slide as someone who does not work with veterans or healthcare workers, but teenagers who are victims of sexual assault and lots of other things. As children, I don't see any PTSD that doesn't have all those symptoms of moral injury. It's there, but they haven't. There were no commissions or omissions. They were children. And so I'm just thinking about how do you think about that? So, and also I'm very excited to follow up and look. I think, as so often happens in psychology, we have multiple strands going. And so we're often thinking about it in terms of traumatic invalidation and people not understanding but I think that probably overlaps a lot with moral injury from what I learned right now. So it's not a very well-formed question, but I'm just interested in your thoughts, because I feel like most of what I'm treating is shame and guilt and not actual fear reactions, even though the person did not cause any of the things themselves.
Yeah. So I think it's such a great question. I think the other thing that we think about a lot that I didn't get to talk as much about today is sort of the betrayal and betrayal trauma and how that factors into everything. And so, I think that's particularly relevant with, working with adults who were children, with children who are like understanding what happened to them, right? And so we really, we've written a bit about betrayal and how betrayal travels very closely with moral injury specifically. And I think that's a really good lens to look, through, because I think it's the same symptoms, shame and guilt, but the source is very different. So it requires different kind of treatment, right? And so I think the incredible thing is like betrayal travels with both moral injury and also with trauma, right? So it kind of infiltrates all of those things. And so that, for me, that lens has been the most helpful, and then also I think, unfortunately, when these things, when you're victimized yourself, you also witness oftentimes in families a lot of horrific things too. So I think that's also can play into moral injury as well. You're welcome.
Hi, Shira. Congratulations on all this fabulous work you've done. We're so proud of you. And I have a question. Have you done research on demographics like women versus men or cultural, and how that has an impact on how to treat?
Yeah, great question. So, I think that in terms of the, specifically race and ethnicity, we know that individuals who are not white basically have 2.5 times the risk of moral injury. So that's kind of one factor. So minoritized groups definitely have higher rates of moral injury when we think about, and again, if we think about, it's not hard to take the next step and understand why that might be. But again, I think we need a lot more research. So your question was about treatment, and I think we're doing that work to better understand how to treat PTSD in some of these groups. So I think we're like way behind with moral injury. And so a lot more work needs to be done to understand what the unique factors are and how to treat those in minoritized groups. And I think in terms of gender, what we know is on the face value, there aren't any gender differences in the rates of moral injury, but that doesn't mean that there aren't differences in how it should be treated with men versus women, right? And so I think more work needs to be done too. So we have some preliminary work on that, but not necessarily the translational work that where we know how men and women may show up differently. Like in terms of the profiles that I showed you, the next step is to look at those broken down by certain groups and see how that shows up differently. And then we'll know how to better treat that. Other questions?
Hi, thank you for your talk. I'm one of the fellows who spends a lot of time at the VA. So just like thinking about in the future how to incorporate some of this in like future workflow. For the like large portion of patients who do have PTSD, but also have moral injury, with like the moral injury being a big part of their PTSD, do you and other people in this space have thoughts or recommendations about how to incorporate that with treatment? For example, like starting with CPT that's more general for PTSD, and then like doing specific moral injury treatment afterwards if like some symptoms aren't addressed, or doing them side by side?
Great question. Yeah, so absolutely. What we recommend is getting your feet wet first in CPT or PE. And the reason for that, I'll kind of flesh that out a bit. The reason for that is a lot of veterans who come to see us have, very minimally talked about their trauma, or sometimes never talked about their trauma. And so I think that sort of is a foundation for being able to just being in a room and getting comfortable talking about difficult things that you did, and also having the experience with a therapist where they're witnessing you, and you learn that they're not going to judge you, that they're going to sort of be there and help you and guide the process. And so we feel that CPT or PE is a really important first step with people who have comorbid PTSD and moral injury. And so and they don't even have to talk about their moral injury at all in those treatments, and so it's just really a stepping stone to get comfortable with identifying your thoughts and identifying some of the behaviors that you're engaging in. And so after you do that, then we think that treatments like IOK can be really helpful as a next step, because then you can kind of get into a much deeper level, after you've had kind of some of the comfort with those treatments. And these are really hard treatments too. I will also say that if you're at the VA, we have clinicians that are trained in IOK there. And so that's something that we can accommodate a small number of clinicians, so there may be a little bit of a wait, but we can offer that as part of their care. So yeah, a stepped care approach is something that we recommend.
Thank you.
Sure, thank you so much.
Thank you.